Hi, everyone. Good morning, good afternoon, good evening, depending where you're joining from. Thank you so much for joining our session. I think a few of you are still connecting to audio, but I'm going to go ahead and begin because we have a lot to cover in our hour together. I'm Carolyn Moore. I'm the Policy and Advocacy Advisor with Spoon, and I'll be moderating today. As we get started, just a quick reminder, if you're not speaking, speakers and participants, please keep your microphone off, keep yourself on mute. Video is up to you. We'd love to see you, but understand it's not always convenient for everybody's bandwidth. So we have a 1-hour session today, and we'll be talking about inequities in nutrition and feeding for children with disabilities. We have a great lineup for you today. You have everyone's bios in the conference platform, so I won't go over them in detail, but please do read them when you have a minute. So I'll kick us off. Like I said, I'm Carolyn Moore. I'm the Policy and Advocacy Advisor with Spoon. I'll be followed by Dr. Zaina Makul, who's a nutrition scientist at Spoon, and she'll introduce our topic and give us a bit more of a technical overview. And she'll then be followed by 3 case studies. We have Pamela Magaro, who's a master trainer with Spoon and the Association of Religious in Uganda, talking about nutrition and feeding and family care. Then we'll hand over to Nhasi Saputi, who's the Executive Director of the Lesotho National Federation of Organizations of People with Disabilities, and he'll be talking about developmental screening and nutrition screening. And finally, he'll be followed by Watson Wandelea of Access to Health Zambia, and he's the Program Officer for Health and Child Protection there. And then we'll have about 15 to 20 minutes at the end for discussion, but please put any questions, comments, reactions in the chat as we go. We won't pause between speakers, but we'll pick those up at the end. And of course, we understand that there's a lot of expertise in the room. So as we go, we'd love to hear whether what we're presenting is similar to what you've experienced, differences that you've seen in other types of inequalities in nutrition or other health issues for children with disabilities, for example. And speakers, just quick reminder, please let me know when you want me to advance the slides, and I'll give everyone a 1-minute warning for time. So we have a quick poll question just to get us interacting a little bit. Emma, could you put that up, please? Okay, I'm not seeing the poll question come up. Zaina, is it showing up for participants?
I don't see it.
Okay, well, let's skip it. We don't want to take too much time. I'll just ask you all verbally what you think, or if you know, is UNICEF's estimate for the number of children with disabilities globally. So we'll just do this sort of the low tech way. Just take a second to think what it might be, or maybe you know. All right, so when we're talking about inequities in nutrition in disability, really the reason that we thought this would be well aligned with the themes within the conference and an important issue to focus on is the main takeaway is that this is really an issue that affects very large numbers of children and can have quite serious consequences. So UNICEF estimates there are 240 million children with disabilities all over the world. And rates of disability tend to be higher in lower and middle income countries. Children with disabilities are also twice as likely to be malnourished compared to children without disabilities, and 3 times as likely to die from malnutrition. So as we're talking about inequities in child health and malnutrition, we know children with disabilities often have higher levels of risk in multiple health and developmental outcomes, but we'll be focusing on nutrition today. So from here, I'll pass over to Zaina Makul. So Zaina, over to you.
Thank you, Carolyn, and hello, everyone, and welcome to this session. Next slide, thanks. Nutrition and disability are closely linked throughout a child's life. We often focus on the top arrow that you see going from nutrition to disability, how nutrient deficiencies can cause disability. For example, vitamin A deficiency causing blindness. And these issues of undernutrition are often framed in terms of disability prevention. However, proper nutrition and feeding are also vital to children who already live with disabilities. One of the many aspects of disability that can lead to poor nutrition, so that's the bottom arrow, is the risk for feeding difficulties. Up to 80% of children with disabilities experience feeding difficulties. And these children have the same consequences of malnutrition as children without disability, like poor health outcomes, delayed development, secondary impairment. But as Carolyn shared, the risk for malnutrition is higher. And this disparity is due to many factors. Next slide. To understand these factors, we can use the International Classification of Functioning Disability and Health, or ICF, as a framework. The ICF provides a conceptual basis for defining disability. It shows us that disability and therefore the associated risks and inequities result from the interaction of two main parts: the individual's health condition, shown on the top of the diagram, and contextual factors at the bottom of the diagram. And as you can see from this diagram, the ICF further organizes information into key components. These key components can come together in this way. A child experiences a condition that leads to an impairment in function. The impairment leads to a limitation in the child's ability to perform certain activities, but then personal and environmental factors interfere with the child's abilities and may restrict their full participation in society and in life. So let's look at these two main ICF parts, the health condition and the contextual factors, and how they apply to nutrition and feeding. Some impairments, for example, those that affect muscles, can make it more difficult for a child to eat and drink safely and efficiently. And that's because feeding skills like chewing and swallowing involve the coordination and strength of many muscles. Also, children with disabilities may have increased nutritional requirements. For example, infants with congenital heart disease burn more energy because their heart is working harder. They need extra calories to maintain weight and grow. At the same time, they may tire quickly and fall asleep during a feeding before they get a chance to get enough nutrients. Also, growth in children with certain disabilities may not follow typical growth patterns. For example, children with Down syndrome are generally shorter than their peers. I've listed some health conditions that commonly impact nutrition and feeding. You see those to the right of the slide. Now, identifying how a health condition can impact a child's nutrition and feeding is important, but it's not enough. We also need to recognize and understand the contextual factors that may hinder or promote the child's abilities and participation in daily life. The second part of the ICF are the contextual factors. Overall, children with disabilities experience a complex range of barriers that affect their nutrition. In addition to strong stigma and discrimination, mainstream nutrition services are often not inclusive or not designed to address special healthcare needs. Families impacted by disability often do not have the same level of access to health and social services. And too often, there's an insufficient workforce skilled in adapted care. There's insufficient representation of disability in nutrition policies, and of course, the big gaps that we see in data and accountability. Next slide. So I want to illustrate what I just shared about the ICF and the two parts with an example that we commonly come across in our work. Let's imagine we have a child with cerebral palsy who experiences muscle weakness. This impairment makes it difficult for him to maintain an upright position during feeding, to chew and to swallow safely. So feeding him is very challenging and stressful for his caregiver without the proper support. So she feeds him last and only a few foods she thinks he can only eat. The family does not have access to a trained professional who can help problem solve how to achieve a safe feeding position. And so with all of these cards stacked against this child, his risks for malnutrition and poor health outcomes are pretty high. But what if we change what we have the ability to change? And those are usually the contextual factors. Give the family support and counseling from a trained professional, assistive technology, educate on disability and stigma. This child may gain better nutrition, more independence, more skill development, and have better outcomes in the long term. Next slide. And that's really Spoon's mission, is to nourish children who are highly vulnerable to malnutrition by empowering their caregivers. We serve two groups of children that often overlap: children with disabilities and children living outside of permanent family care. We're currently active in 6 countries, and you'll hear about our work in 3 of these countries. Next slide. Our intervention model works towards building inclusive system and includes 3 main parts: training in adapted care, a digital tool called Count Me In, and data-driven advocacy. Next. The first component, the training, consists of in-person and online training packages depending on the need and the context, so it's flexible. Our participants include a wide audience of medical professionals, community health workers, social workers, educators, policymakers, and reaching a wide audience is important given the many potential entry points to deliver support and services to children with disabilities. Because not every participant has a disability or nutrition background, it's important for training to include a foundational package in addition to specialized topics like specialized feeding techniques and how to adjust positioning for feeding. Next. The second component of our intervention model is our app Count Me In. Count Me In is designed to bridge the training that we have with nutrition care delivery for children with disabilities, while at the same time generate data. It's a web-based app and has 3 modules: growth, anemia, and mealtime or feeding. On the left, you see screenshots for some of these modules. Each module has a series of questions and tasks that guide the user, a nurse, for example, to assess and monitor feeding difficulties, growth, and anemia status for children over time. After each assessment, the app generates individualized care plans, including WHO growth charts and nutrition and feeding recommendations. Users also get data and easy-to-read reports to assist with decision-making, and you see screenshots of some of these reports on the right. We recently added a developmental screening module that you'll hear about in one of the case studies, and are currently working on an offline version of Count Me In. Next. And finally, the third component is data-driven advocacy. We always use data generated through Count Me In and outside of Count Me In and lessons from our work to raise awareness of the need and advocate for disability-inclusive nutrition through different types of outreach and policy input. Next. So next, you'll hear about 3 case studies of how Spoon with our local partners have applied this intervention model of the 3 components in 3 different countries and contexts to create more inclusive systems And each of the case study used a multi-sectoral approach, contextualization of our interventions, and partnerships. And our first case study is from Uganda, and it will be presented by Pamela. So Pamela, over to you. Thank you.
Thank you, Zaina, for the presentation. Pamela Magero is my name. I'm master trainer and nutritionist for Spoon and Arus CCC. I'll be discussing or talking about strengthening nutrition and family care and experience of Catholic care for children in Uganda. Next slide, please. Okay. So the project is a collaborative effort between Spoon Foundation and Association of the Religious in Uganda's Catholic Care for Children in Uganda. The goal is to strengthen nutrition and feeding practices for children living with disabilities and children currently at risk or living outside permanent family care. Our project objectives are to equip childcare institutions with nutrition and feeding knowledge and skills to support them to implement best feeding and nutrition practices for children, to ensure the children served by these childcare institutions are eating more efficiently and safely, and also experiencing improved growth and reduced rates of anemia. We support CCI staff to incorporate nutrition and feeding into community outreach activities to inform and influence community stakeholders, including the families. The other objective is to develop guidelines on incorporating nutrition and feeding into alternative care and reintegration policies and programs for use by key stakeholders in the sector of nutrition. Next slide, please.
Pamela, it's excuse me, it's a little bit faint compared to your test. So if you could try to speak up just a little bit, that would be great. We can hear you, but it's a little quiet.
Okay, thank you. Yeah, so our project interventions in Uganda, one is we do nutrition and feeding capacity building in 17 childcare institutions, and these are across the region. So they are sparsely distributed around the region of Uganda. We do training in growth monitoring, anemia assessment and management, mealtime screening and observation. We use Count Me In, the application that Zaina talked about, for tracking growth for children, support decision-making and monitoring for the health of children. We also do advocacy for disability, inclusive nutrition policy and practice. Next slide, please. So building on the discussion that Zaina had about the link between disability and nutrition, I'll specifically go into family care. So the quality of family care can greatly impact the quality of life for children. One specific concern and challenge that families in Uganda face is gravely around poverty. So you find that families with children with disabilities, on top of being poor, fail to make the right choices of food for these children. They cannot access the necessary equipment to support feeding children safely and efficiently, which often compromises the situation of the children who are already disabled and leads them into malnutrition. So without support, family care can greatly be impacted by disability, malnutrition, as well as feeding difficulties. Next slide, please. So some of the reasons why inequities for children with disability often exist in our country and are stigma and discrimination. This has resulted into marginalization, exclusion from nutrition programs. You find that the children stigma stems right from the household that is affected, because parents and caregivers often tend to stigmatize themselves and feel excluded from the community as a result of the condition of their child. And when you top this up with the already existing stigma and discrimination around disability in the community, you find that children affected often end up in institutionalized care, and there are high chances of abandonment for such children. There is also lack of sufficient data to support policy and programming, and this is also attributed to the stigma because most of the children are hidden, some in the goat houses, in the shacks, and you find that even when studies out there go to find data around disability, the mobilization doesn't turn out right, and so the numbers do not support policy. There's little evidence as a result. So there's also lack of inclusiveness at governance and policy levels. For example, the Ugandan curriculum at higher institutions doesn't clearly talk about nutrition and disability, which is a gap in supporting programs as well. We have inappropriate feeding care, knowledge and skills to safely nourish these children, especially for the caregivers. Next slide. So our reunification program here in Uganda includes sensitizing parents and caregivers on the unique feeding needs and aspects for children with disabilities in comparison to other family members to provide them with the necessary tools to support the children in their care. We are also engaging community leadership and justice institutions to safeguard the safety of these children. Oftentimes, because caregivers know that the condition of disability will not go away, they might not be received very well in the community, and often there are high chances of relapse. So with the use of the family unit in the probation office at the police, we have supported ensuring that children are kept safe in the communities where they are reunified. We also do community sensitization outreaches through the childcare institutions to promote acceptance and easy social readjustment for children living with disabilities. Next slide. So from data in Count Me In, these are the current trends in malnutrition indicators for children with disabilities. So at baseline, we had stunting at 52%, and most recent assessments show that it's now at 42%. We had underweight at 36% and is currently at 23%. Wasting was at 10% and now at 1%. And anemia was at 91% and currently at 57% as a result of our intervention.
Emily, you have just under a minute left.
Yes, please. Next slide. Yeah, so some of the recommendations given the experience we've had is one, to prioritize the role of nutrition and feeding in successful resettlement for the care reform process, to prioritize children with disabilities in national nutrition policies, guidelines, as well as legal frameworks, train health, nutrition and childcare professionals on disability inclusive nutrition, screen all children for malnutrition and feeding difficulties in the resettlement process, then collect and use data on the nutrition status of children in alternative care, and finally disaggregate data by disability status to ensure accountability for inclusion of nutrition of children with disabilities. Next. Thank you for listening to me. I'll now pass over to Nkasi from Lesotho.
Yes, thank you very much, Pamela, for that. My name is Nkasi Sifuthi. I am the Executive Director of the Lesotho National Federation of Organizations of the Disabled, LANFOD in short. So my presentation will be on linking developmental and nutrition screening in children. This project that I'll be presenting about is actually a collaboration between Lanford Spoon Foundation and Johns Hopkins University. So, like my colleagues have already said, that there are inequalities that are facing children with disabilities, and these include lack of data, poverty, malnutrition, which normally hinder them from growing just like any other children. So lack of data also contributes towards lack of well-informed policies and interventions that could be done for these children, lack of guidelines and standards for early identification is some of the challenges or barriers which these children are facing. So this project is actually, the goal of this project is to identify developmental delays and risk from the ages of 0 to 6 years. And this project is done in collaboration with the government departments that are responsible, including the Ministry of Health and Ministry of Social Development, Ministry of Agriculture and Food Security and Nutrition, and the Ministry of Education, because they are directly involved in the growth of children, and they are responsible for identifying disability at an early stage. So now we'll be dealing with what is this developmental screening, and it has been said that the developmental screening involves the identification of developmental delays in children and risks, including their functioning. So that this is a process whereby we are trying to identify developmental delays or disability at an early stage. And here we should make a caution that here we are not talking about the medical diagnosis, but we are talking about the process which may help us to identify the risks or the developmental delays, which will then be referred to the medical institutions for their in-depth assessment. So now, why is the developmental delay? Why is this developmental screening important? This is very important because number one, it promotes inclusion because children with disabilities will also be able to be identified at an early stage, and being identified at an early stage means that they'll be able to access opportunities, and they will also be able to get early interventions, because normally these children, they don't get early interventions, and that results into inequalities which they always face. So the early identification on itself is an opportunity, because if these children are being identified at the early stage, then the early interventions will be provided, and the hope is that they will be able to access opportunities and access health services just like other children. And the developmental screening itself, when it is existing with appropriate tools, will also help in ensuring that these children are also able to get the services that they need. And there will also be better developmental and parental outcomes for children, and the parents will also be able to know where to take their children and to get the specialized services for their children. So let's just look at how it has been done in Lesotho. Like I said before, we have built a team of different aspects from different ministries, which is a core team. And now this core team actually is working with the project team to ensure that the project is implemented in accordance with the objectives of the project. And in this case, what is happening? Well, what is happening is that the project is being implemented in It's been piloted, in fact, in 2 districts at the moment. And the pathways for the implementation of this project has been number one, through training. Spoon conducted hybrid training in the beginning, whereby first of all, they trained 55 master trainers. And then now after that, there was physical training, whereby the master trainers were fully trained on feeding and growth and early identification in Lesotho. And now after that, the master trainers were now able to go to the pilot sites to train the staff that are working in the pilot sites. And then in the pilot sites, we have the schools, the preschools, which have been identified, and we also have the health centers. So in the health centers, we have nurses that have been trained on Count Me In, which is an app that my colleagues have already talked about in the beginning, and we also have children in the preschools. So what is happening is that for children from 0 to 3, they are being assessed or they are being referred to the health centers, but for children from 3 to 6, they are being assessed. They are being identified at the preschools in which the data of these children is being entered into the app. And then where there are a need for referrals, then these children are being referred to the health centers that are nearby. Hello? I'm sorry, I don't know where I was lost.
Yes, we can hear you well. I'm on the slide that says developmental and nutrition screening, training, and tool.
Cassie, you are on mute.
Oh, I'm sorry, I don't know what is happening, but okay. So now we are at the stage of the pilot, and we have been using the Count Me In, which has been used to collect the data for these children in preschools, and now we have the preliminary data which has been collected through the app, and you can tell from the data here that we have been able to collect data on growth, on assessment, growth assessment. We have also been able to collect data on wasting and stunting. So these are the preliminary results of the work that we have been doing through the Count Me in the pilot sites. So now we are looking at the opportunities and challenges that have been seen during the implementation of this project. So I will start with the opportunities. So it seems to be integrating well into the care flow at the clinics for children under 5. It works very well with the preschools, and it has been praised by the parents at the schools. And it is able to provide referrals for children in the same communities. And it has been quite interesting for the teachers at the preschools, since parents have been providing positive feedback about it. So in terms of the challenges, the users at the health centers have said that sometimes it is very slow because of the network. And the other challenge is that it increases the workload of the nurses, because nurses also have a lot of work to do at the health centers. But since they have to use this app, and then it seems to be increasing their workload. So the other problem is the lack of specialized services, that even if the children have been referred to the health centers, but now the problem is that sometimes there are no specialized services that are needed by children with disabilities or children who may be at risk of having disabilities. So the other big problem is the limited government resources to integrate this program into their systems, and this also presents a challenge and in terms of accessibility, in terms of sustainability of the project. I think for that I will stop here, and that will be the end of my presentation. Thank you very much, and sorry for the disturbances that have been seen during the presentation. Thank you.
Thank you so much, Nhasi. I will introduce our next speaker is Watson Wandelea. He's the Program Officer in Child Protection and Health with Access to Health Zambia, and he wasn't able to be with us live today, so his video, his presentation was pre-recorded.
Hi everyone, you're welcome to this part of the presentation. My name is Watson Wandelea. I'm the Program Officer at Access to Health Zambia. I'm going to present on supporting nutrition and feeding for children with disabilities and families in Zambia. So I'll just run, this is the situation of children with disabilities in Zambia. Here, for example, I have 4.4% of children 2 to 7 years old who have disabilities, and that 40% of disabilities was a result of congenital causes, which we have 31% due to illnesses. Leading causes are yellow fever, meningitis, non-treated malaria, and poor nutrition in early childhood. These are some of the challenges caregivers pass through here in Zambia. For example, we have poor nutrition in children, and also lack of skills in feeding techniques. So Access to Health Zambia with partners implement Kusamala project, whose objectives are to reverse family, community, and system tolerance for harmful practices, build families' capacity to provide stable, protective, nurturing family environments for children, build support for child-friendly practices, and to reverse tolerance for those that do not support children's positive parenting, positive development, and that includes positive parenting as well. So this is how we work with caregivers. We have Count Me In that assess children, pre-therapy sessions, household visits, cooking demonstrations, trainings, and we also do advocacy activities. So Count Me In has been able to assess about 1,515 children. And of course, it shows that 78% of children are showing one or more indicators of malnutrition. Recommendations that are in Count Me In are specific to each child's needs, including specialized feeding techniques, responsive feeding, and ways to ensure an iron-rich diet. So just to run you through activities, so we have household visits and community caregivers that are trained do conduct 2 household visits per month, where they do basic physiotherapy, nutrition counseling, referrals, and other services. At pre-therapy sessions, children have an opportunity to interact, communicate, and also socialize with other children. Cooking demonstrations working with Ministry of Health are meant to support parents laying different balanced diet meals. So here they choose different recipes that they present, and of course with the guidance of a nutrition expert. And we encourage parents, of course, here to have backyard gardens where they do plant some fruits and vegetables. These are trainings that we conduct, and all of these training at master trainer level, as well as our ROAT level. We have disability and nutrition, care for children with disabilities training, and also the Feed Safe, which is a tool to promote safe, effective, and comfortable feeding practices. We do conduct advocacy activities both at community and national levels. We have messages at community levels. We have messages at community level that are focused on stigma, inclusion, and also disability-led flags presented at church, health facility, during dialogue meetings, and as well stakeholder meetings. At national level, the TAG, which is the Technical Advisory Group meeting, is important because this is where we review important documents as well as policy briefs. And also this is an opportunity for the team to share the company in data. These are some of the program outcomes. An adjusted program data and company initial positive trends in anemia and wasting. But of course, we are not seeing significant change in stunting, which is a bit of a challenge. We have decreased community stigma. We have increased referrals for children with disabilities. And also, we have increased capacity of government institutions like health facilities and social welfare services to support children with disabilities. Some recommendations includes prioritizing disability inclusion policies, guidance and budgets, incorporate nutrition into all programs serving children with disabilities, support health workers, including community health workers, to provide disability inclusion, inclusive nutrition services, for example, GMP. Also increase funding and coordination among organizations supporting children with disabilities, and also improve data and accountability here, because here in Zambia, it's quite difficult to get data around disability. Thank you so much for listening. I'll wait for questions. Hi, everyone. You're welcome to this part of.
Thank you so much to Watson. And so we are almost to the discussion section, so please get your questions into the chat if you have them. And I'll just quickly wrap us up with a few recommendations and things that we are advocating for as Spoon and our partners. So I think as you see across the different case studies, there are quite a few ranges of things that we can do and different partnerships that we have. But across the board, there's really a need for change across the ecosystem towards more inclusive services for children with disabilities. And that can include things like prioritizing children with disabilities in policies, guidelines, accountability measures. We're really pushing for more investment specifically targeting the needs of children with disabilities and their families. Of course, there's a need to proactively include children with disabilities in services and programs and make sure that the health workforce and workforces in related sectors have the knowledge and skills and support that they need to make sure those services are not only accessible to children with disabilities, but appropriate for their needs as well. And then finally, advocating for more data and accountability, both on the needs of children with disabilities, but then to press for inclusion and to monitor inclusion in services as well. So I'll move us into our discussion question, and I'll stop sharing my screen so we can all see each other a little bit better. Panelists, I invite you to turn on your video if you're able to. And tech team, I'm not sure if we can pin the panelists, but if we can, that'd be great, since we have a big group here. I will get us started with a question that I was thinking about a little bit after the plenary this morning for me. You all mentioned the need for working across multiple sectors. And I think you had some great examples of different sectors that you're working with, and that's been a theme of our discussion so far. I would love to hear a little bit more what advice you might have for others who are working across multiple sectors towards more inclusive systems for children with disabilities or for children in general. Pamela, I'll start with you, and then I'll come to Nhasi and then Zaina. And just a reminder for everyone, if you're not speaking, please keep yourself on mute. Thanks so much. Pamela, over to you.
Yeah, thank you, Caroline, and thank you for that question. For organizations or individuals that would want to work towards inclusive nutrition work and policies, especially for children with disabilities, the first thing I would advise is to benchmark best practices. Map organizations maybe that are already working with children with disabilities, especially in the area of nutrition. Learn from them, listen to their lessons, and benchmark what practices you can then incorporate in your work to support nutrition for children with disabilities. Thank you, Caroline.
Thank you so much, Pamela. Nhasi, same question for you. What advice would you have on coordinating across multiple sectors to improve outcomes for children with disabilities? Nhasi, you are still on mute. Okay, we've been having a little bit of trouble with Nhasi's audio, so Zaina, why don't I come to you next, and then Nhasi, I'll come back to you.
Great, thank you, Carolyn. I think it's important to make sure each sector understands what their roles are and responsibilities. If there are not clear roles and responsibilities, no one would end up taking accountability for how they could contribute to these inclusive systems. We did have like an example from Lesotho where we're trying to reach children through health centers and preschools, but then there's this age group that receives services through ECD centers. But no ministry is kind of taking the responsibility of these ECD centers. So Ministry of Health says it's education, Ministry of Education says it's health, and a lot of the times these children fall through the cracks. So I think having clear roles and responsibilities for the different sectors is going to be important, as well as having standard tools and guidelines in place, especially for early identification and how that could lead to early intervention.
Thank you, Zaina. Nhasi, back over to you. Is your audio working okay now?
Okay, thank you very much. Yes, I think the issue of budget is very critical in work such as this one, because most of the work that will be done there will definitely require some budget for the team to come together and also to implement their activities. So I think as much as it's very important to have a multi-sectoral approach, but we should also provide that kind of setting with the resources which they may need to carry out their work. Thank you.
Thank you so much, Nasi. Okay, we have a question from the audience, which I think maybe we'll start this one with you, Zaina. Count Me In looks to be filling a large data gap in nutrition and disability. What plans are there to integrate this tool in the health system / education system? And maybe I'll add on to that too, if you could just clarify a little bit about sort of the linking between nutrition screening and developmental screening that it now offers as well. Thanks for the question.
Thank you for that question. So where we are using Count Me In both the health and education system is in Lesotho, and that's the first time we kind of are piloting this model. We know that children we're accessing through the health centers, children ages 0 to 2, are the children getting ready to get into preschools. And so we want to give them the best chance possible. By implementing early identification, if we're able to kind of detect risks for delays or difficulty in functioning early on, we could begin these early interventions early. And so they can begin their education and we could put them on a good trajectory. So right now with Count Me In, we're still in the pilot phase. We are in the process of interviewing our pilot participants, the teachers who are using Count Me In at preschools, the nurses who are using Count Me In at health centers to learn about the feasibility, acceptability, and usability of Count Me In, and how that pathway that we're piloting, how it works in Lesotho. Based on what we learn, we will be working throughout this next phase of the project. We will be working with the different ministries to see how we could scale to different districts, but also, as Hasi mentioned, the issue of resources is a big one. So how can we integrate Count Me In into existing structures, like integrating Count Me In through e-registers that they have in Lesotho to make sure it's a sustainable program. So that's something we're working on currently.
Zaina, thank you so much. And there is a question in the chat about the specific tools that are being used. So maybe if you could just answer that in writing, since we don't have a ton more time. And Karen, thanks for your question about play therapy. Our speaker from Zambia isn't with us live, so I'll ask him to answer that question and we'll get that answer to you. I know there are a couple people in the audience who work on that program as well. So please feel free to also answer that by chat as well. We have some great commentary as well from a similar situation in Cameroon and collecting data to support advocacy, including some donor-facing advocacy. So that's very exciting to hear. And I wonder then if we could kind of have our last question for you, Pamela, if you could share a little bit on kind of what you see as the need for additional data in the Uganda context. And maybe share a little bit on how the project has been able to contribute to filling that data gap so far and what the plans are to come.
Thank you, Caroline. So currently, we've trained close to 50 caregivers on nutrition management for children with disabilities, and we have reached over 300 children in our project. Now, in an effort to support data collection and evidence gathering in our latest phase, we have embarked on a journey of data collection where we are going to reach out to more child care institutions, not only those affiliated to Catholic Care for Children in Uganda, and gather as much data as we can to support evidence gathering and possibly support our endeavors in advocacy and raising awareness to bigger agencies in the sector of nutrition to support policy and programming. Thank you.
Thank you so much, Pamela. So I think we'll have just maybe 1 more minute in our Q&A, since we want to make sure there's enough time for us to be guided in our transition to the next section. So I'll just go back through each of our panelists and ask if you have any closing remarks. So I'll go first to you, Zaina, and then Hasi, and then Pamela. We'll wrap up from there. So Zaina, please go ahead.
Thanks, Carolyn. I think understanding these inequities is going to be very important to design interventions and programs that work within the context of that country or that community. As we heard about stigma in each of the case studies, and it's and that can be a huge barrier to the success of any program. So I think kind of thinking of that ICF model in order to kind of organize our thoughts around understanding the barriers and the facilitators for children with disabilities and how that links to their nutrition status and health outcomes in general is going to be important. And then making sure these interventions not only take into consideration the health condition, but also these contextual barriers. Thank you.
Thanks so much, Zaina. And Hasi, any closing thoughts before we wrap up?
Yes, thank you very much. Yes, I think it is very important to understand these inequalities and also for our government to integrate these interventions that we have been sharing into the health system so that children with disability can be included. So we already have the model through which children with disabilities can be included, and it just need to be sustained and be scaled up, and we will definitely need support to do that, to support our government to sustain this project and to turn it into a program that will benefit all the children across the country. Thank you.
Thank you so much, Hasi. And Pamela, over to you for any final comments.
Yeah, so for me, my appeal would be that organizations come on board, especially those in the nutrition sector. The group of children with disabilities or persons with disabilities seems like a complicated one, but results are fulfilling, they are worthwhile, and I would appeal that it takes each of us as individuals to take part in causing change, and together as different sectors and organizations, we can put hope and create good health for children living with disabilities.
Thank you so much, Pamela, and thank you to all of our speakers and to our audience for the great questions. I wish we had more time to continue this discussion, but I'll pass over to Kriti now to let us know how to find the next session.
Thank you so much, Carolyn, and thank you for the great moderation. Thank you to our speakers and our audience. Our next set of concurrent sessions will start in 30 minutes, but in the meantime, please feel free to join the discussion tables and the poster halls. You can access those through the conference platform. Thank you so much.